Okay, so here we go. It's now 7:59. Thank you so much for attending, and most importantly for your patience, and thank you for Vipin's daughter to save the day. I've already mentioned this a couple of times, but a couple of exciting announcements. Number one, we've hired a social media consultant who obviously is well overdue. Clearly, I don't have a clue what I'm doing. So we're trying to raise our profile in social media. Although we've had accounts, we've used it just to try and drive members to our annual meetings. Clearly with COVID and just today, the announcement of vaccines being released in Canada, I can't even see us having an annual meeting next year. So the reality for us and so many educators is it's going to be virtual. So we are working hard to get back into social media. You'll be seeing hopefully Facebook and whatever other ones are appropriate. We also have opened a channel on YouTube. So you can go to YouTube now and just type in our name. You have to type it all out. And you should see the last lecture by Dr. Dennis Bailey, which was given about 3 weeks ago. If this works, you'll also find it. But I'm also committing to all of you tonight and to all the whole membership that you'll get a link to this recording. And I'll also send the PDF of the actual presentation. Some of the charts I'm going to present, the text is too small for you to read probably. So I'll walk you through it. That's simply the results. But everything else hopefully is big enough for you to see. So that's what to look for in the next while. This will be our last webinar until the new year. It's getting too close to the holiday season to beg your attention after a long day at work. That's
Okay.
the story.
Your phone is up here. Can you do me a favor? Bring my drink up, and I need an extension cord to plug my phone into.
And the last thing I need to say, which was just underlined, if you could mute yourselves, I'm not going to try and intercept my talk and screw it up again. So if there's a lot of background, just you can mute yourselves. At the end of it, lots of time for questions and answers. So without any further ado, let's go. So you all know who I am. The name of the topic is a bite registration that really works. The really is the important part. As you know, I've been saying this for a long time. I was taught this years ago. We as dentists do not want to turn a snoring patient into a silent apneic. In other words, it's not good enough to make an appliance and it's generally not the patient, but the family members say, "You did a great job, doc. He doesn't snore anymore," or "she doesn't snore anymore." You need to know what's below it, which is the most important. What are we going to learn tonight? We're going to have a quick review of one of my favorite topics that puts most people to sleep, called the osteopathic model of medicine. We're going to overview a little bit of TMJ anatomy. Those of you who know me, I'm a TMJ guy first. We're going to demonstrate with actual videos how to do this technique. You will learn how to do this tonight. You can do it tomorrow because you have the supplies. You don't need any fancy equipment. You don't need any fancy supplies. You can do this tomorrow. And we're going to review the actual reduction, the AHI reduction in all types of sleep appliances using the technique I'm going to present tonight. Normally I put this copy in 4 or 5 times, but just to remind us all, this is a dental meeting. As licensed dentists, we cannot legally diagnose sleep disorders. We need to work with our partners. And as founder and president of this academy, you need to know, I've said it publicly, I'll say it again tonight, this is one of the hardest things we've done in trying to get our medical partners to come to the table. But technically, your patient needs to have been diagnosed, usually with a sleep study. They'll come to you either not wanting CPAP or have tried it and it didn't work. And with a simple piece of paper, which allows you to actually proceed and do what I'm going to show you tonight, we can be valuable, indispensable members of the dental sleep medicine world. Very quickly, just to remember that part of my training is that pain, TMD, and airway disorders are all connected. Your patient may complain of bruxism, they may complain of sore jaws. You may not think to ask them on recall how they sleep, but it's all connected, and I'm going to help you with all that tonight. As you know, I have a practice limited to TMD and sleep disorders. I do not have a general practice. It's a referral-based practice. So everyone that comes to us knows about us, was sent to us by other health practitioners, or as it turns out, 50% of our patients come from former patients. I have to remind myself and my staff and my patients of the following items. They also may exhibit TMJ structural problems, even though they're a quote unquote a sleep patient. The night guard they makes them clench more. I'm not going to dwell on this too much, but all we were ever taught in most dental schools in North America was to make a night guard or a bite plane or a flat plane splint. And it can fit on the top or it can fit on the bottom. It can be thermoplastic or not, but all you've done is given them a sheet of plastic to chew on, and it doesn't really address either of the issues we're going to talk about tonight. These patients go to bed in sympathetic overdrive, which means they've been chased by the tiger for days, weeks, months, or maybe years. They're exhausted. And they may also have a restricted airway, which may be one of the reasons they're clenching and grinding all night, because most of us don't want to not wake up tomorrow. They're exhausted. They're in pain. They're frustrated. They're anxious. They're not happy. And if they're patients you've known for years, and that's the advantage you have over me, because my patients come on a short term and I don't know them as well as I might have known someone I've looked after for 25 or 30 years. So just keep that in the back of your mind. Now, everybody who comes to my office sees this. This is a patient in a sleep study. Can you hear it okay? You're going to hear heavy wheezing. This is not snoring. This is wheezing. Any second now, his brain says, I'm not breathing. And just, I don't know if you can see my cursor, but in a few minutes, his stomach starts rocking and rocking back and forth, trying to create an airway. This man's overweight. He's on his back. His pillow's elevated. His neck is too thick. He's just compressed his airway, and his brain knows he's not breathing. I show this to every couple. Most patients think Uncle Charlie only snores. You can hear. So for 40 seconds, he struggled. This video would show him pulsing and thrashing about, and it takes 40 seconds for him to get a mouthful of air. You may know this already, but all that medicine records is an inability to breathe for 10 seconds or more. Most of our patients have apneic events that can last 40, 50, or even longer, a minute and a half. And when you make them understand that if they tried to hold their own breath for half a minute, 50 or 60 times an hour, they wouldn't believe it's possible. That's an adult apneic event. Anybody who's gone for a sleep study has been through one of these, and it's pretty scary when you show folks. This is a normal airway. You know this. We learned it all in school. We work in the oral cavity. The back of the tongue, the soft palate, is where constriction starts. On your back is the worst position for sleep. This picture is cut off, but at the back of the throat, the tongue and the soft palate can either constrict the airway or totally block it off. And that is the risk. Side sleeping is generally more successful, but a lot of people like to sleep on their back. I'm not even seeing my cursor here, so you have to just work with me. Snoring versus apnea. The most important thing for you to understand and to make your patients understand is that those two vastly different conditions connected to the same person within the same minute. I have for years told patients that snoring is simply a social problem. Apnea is a health problem. Most times the patients are unaware of either one of them in themselves, but their bed partners or family members down the hall, or the golf buddies, or the hunting buddies, or the girls who go on a getaway for the weekend and shop will always point to the girl that they're not going to invite next year. It's better to have the patient make noise consistently, called snoring, as opposed to the video you saw where there's some noise and 30 or 40 seconds of sleep apnea. That's not good. This will sound very basic, but this is how I talk all day long. And I tell patients that it's simply a plumbing problem. You got a pipe that collapses really easily. And they come in all different sizes, but we need to keep our airway open at all times. If I asked every one of you to put your pens down and stop listening to me and hold your breath for 40 seconds, except for scuba divers and very fit people, you probably all would, after 15 or 20 seconds, start to turn blue and gasp and choke and not be able to pass the test. When you see a patient on recall, when you see someone in a store, look at the neck. When you see an open collar shirt, we're all now in business casual. You need to take a look and think about the circumference of the neck. Depending on who you read, for females it's 16 inches, for males it's 17 inches. As it turns out, the size of your neck does in fact matter. Can everybody hear me okay so far? Another very basic concept. If you have a garden hose, a cheap garden hose, all you have to do is bend it in half and cut the water flow. That's quite easy. We've all done it as kids. We waited for our sisters to look in the nozzle and we unkinked it, and they got a face full of water. Just think about the water being air. If you want to simply reduce it, you can put a squeeze in it, but not obstruct it. That's called hypopnea. Apnea and hypopnea together are considered equally serious and are counted on 100% value relative to each other in a sleep study. It's far better to have hypopneas than apneas. This is an overlay of a man sleeping, and I won't talk and see if you can hear it. Patients will wake up once or twice a night thinking they've choked, wondering if they woke themselves up with gasping and choking. So if you think of nothing else, tomorrow when you're at the office and you're doing recall checks, look past the teeth, take a look at the airway. Our education ended at the end of the tongue. You're looking at a fairly normal flat base of tongue, soft palate, and a uvula hanging down, and the two areas on either side of the uvula is all the room there is for air and food. A normal airway would look like this. I'm also trying to admit somebody. And now I'm stuck. Oh, yeah. Here we go. There are two pictures, top and bottom, the normal airway and the one that you'll see a lot of. And I'm sorry, but my cursor isn't working, but you'll see a very long extended uvula. You'll see a very large tongue, a bifurcated tongue, and two sacs on either side, which are the tonsils. At rest, when you're upright, you can still breathe. Just imagine lying that patient down, soft tissues relax, gravity takes over, and these people occlude their airway very easily. Whether they breathe through a straw or not at all is a significant concern. Now, I'm going to keep, now this is a close-up, and you can also see this without any difficulty at all. This is tonsils that are on either side. There's two big red balls, and the tip of the uvula. These would be called grade 3 tonsils. They go from 1 to 4. Essentially, you divide the airway in quarters, and as each tonsil approaches the midline, it's either 1 quarter, 2 quarters, 3 quarters, or 4 quarters. Class 4 tonsils are touching. They're called kissing tonsils. They're often covered with bacterial plaques. You may have children or grandchildren with them. In Ontario, at least, it's very hard to get an ENT doctor to consider removing them. Probably the best thing that could happen for these patients. Another way you'll hear people talk about the classification of the airway is the Mellon-Patty classification. Patients sitting up or standing upright, extending their tongue. Again, you'll be able to see the classic Gothic arch of the soft palate with the uvula hanging down. And as you go from left to right, as the airway appears to decrease, you can imagine that in the right side, number 4, class 4, there is no apparent airway on an upright patient awake. Dip them down and let gravity take over, let their jaw fall back, and you can probably appreciate how the airway can collapse. We need to own this area of healthcare. For those of you who attended our last webinar with Dr. Dennis Bailey, he spoke very well about the nasal airway. His topic was the nose. You need to remember that nasal breathing is the preferred method for respiration for all patients. We should all be able to breathe through our noses effortlessly, continuously. Every one of you should be able to sit listening to me with your lips closed and be able to breathe easily. Coming from this concept is a brand new growth hormone that's been largely ignored. Those of you who have children might worry about your child's percentile on their growth chart. The new growth drug, which has been released recently, is to be taken continuously. It should be taken nasally if at all possible. And with its use, you'll have wide, healthy faces. Does anyone have an idea what the name of this drug might be? Shell it out. Anybody want to throw it out? You're right. It's called oxygen. Guess what, folks? We don't get enough of it. Oxygen only makes up 20% of the room air you breathe. It has to be delivered to the lungs where it's extracted and deposited in every blood cell and delivered to your body. It's the gas in your engine. We need to breathe more through our nose easily and effortlessly. Clearly, I backed myself up, so we're just going to keep going. And the next slide should say, okay. Now I'm stuck. What is going on here? I don't think I'm going to be, oh, here we go. So now we're going to do a quick overview of TMJ only because this is my focus, but you have to know a little bit about it. I have a lot of, I mentor a lot of folks. I take a lot of phone calls, and I know we learned very little about TMJ. Don't worry about it. What I'm going to show you tonight, you can master it. There's a picture of a mandible. The blue arrows point to our area of expertise. We're teeth doctors. We're very good at straightening and fixing and aligning and removing decay and putting crowns and now implants. And we can do all kinds of wonderful things with the teeth. We learned very little about the two things at the end with the red arrows. They're called condyles. That's where your jaw hinges. It's very far back from where you think about it. It's right by the ear. It's why a lot of our TMJ patients go to their doctor because their ear hurts. This is a composite of tomographic slices of TMJs that I take in my office all the time. I've handed this out to many of you. In the upper middle picture, you'll see a tomogram, which is a slice of a condyle. It's a very, 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 very inexpensive, very crude version of a cone beam or a CAT scan, but it shows the center of the condyle in the glenoid fossa well ahead of the ear canal. It's a big black hole in the upper left-hand side. Most jaws need to be centered in that fossa, just like most knees and hips need to be centered in the socket. We don't like to be walking bone on bone. If you go down to the bottom left, you'll see patient LA pre-treatment. I believe this was a early 30-year-old lady whose job it was to be a medical transcriber. She sat all day long in a dark room listening to doctors transcribe, cough and choke as they blurted out their messages. And she ended up with headaches, earaches, and got referred to us. Her jaw was up and back. It wasn't not touching yet, but close to it. To the lower right side, patient LA with an orthotic. When you center the condyle, amazing things happen. Displaced condyle, upper right side, you can almost imagine that bone being morphologically shaved to fit into the socket. Upper left, severe bending. A new dental assistant to my office about 15 years ago when I gave a similar kind of talk as a lunch and learn to my own staff. After I went on my little tirade about how we need to do better, she pulled me aside and said, "Doctor, everything you just talked about, headaches, jaw pain, earaches, irritability, not sleeping, that's me. I had braces when I was a kid. I had bicuspids extracted. I had headgear. Then I had 2 jaw surgery. And ever since then, I've felt like crap." And I took a picture of her condyle. It may be hard to see, but this condyle has bent right around in a semicircle to actually make the head of the condyle fit into the small fossa. It's called Wolff's Law. Bone will move under tension. So the center healthy position is the picture you're going to see more of tonight. How do I do it? Well, this is a machine that you can no longer buy. It's a very old version. It's called a panoramic CMT, complex motion tomography. For anybody who's been to my office, when you look at the exposure head, it wiggles all around and it records what's called the center slice. So very quickly, we can get a sense of at least what's the shape of the condyle, where does it fit in the complex. The ideal healthy position. Again, you want space around the head of the condyle for the articular disc, muscles, ligaments, tendons, and most importantly, a neurovascular bundle. This is a schematic of what we probably all were taught in school. You need to have a disc between the bones. As it turns out, Mother Nature realized in advance we wouldn't be very good at this. So I want to see if I can admit Dan at the same time. Sorry, Dan, I don't think I can admit you. We need to have lots of space for the disc. As it turns out, the cartilage in our jaws is a little more durable, and as a result, we can function, but not with good care. This is a video.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. In this joint, the disc is anteriorly displaced and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing. The disc is here.
It might be hard to see. The lower left is the condyle. The upper right is the glenoid fossa, the cranial base. And when we move our jaws past halfway, we take our jaw right out of the socket and it slides back in. We dislocate ourselves bilaterally hundreds of times a day and not know it, unless we have one or more discs slipping off or on, creating noise, pain, and dysfunction. And often patients will say their jaw locks. What they mean is, as they move through excursions, they'll get a clicking or a popping. This is what we have to be aware of. Here's another close-up of an unhealthy jaw. You can imagine there being virtually no space for soft tissue. I use all kinds of analogies that are non-medical to my patients. When you flip back to the healthy one and imagine a big circle of darkness, I tell people to think about that as the x-ray of one of the tires on the car that brought them to our office, and think about the black as being all the air that keeps the tread off the wheel. Then I show them their own and ask them what they think about their tire, and universally they go, if I've done a good job, they say it's fairly flat, and that's basically what we do. Here's another quick sketch of the disc popping off the condyle. I just want to get you to think about how I approach our patients. And it looks like I'm going around in circles. Why am I doing this? Oh my goodness. This is not good. I'm going to have to it's going backwards. I told people years ago, if you get a Mac, you never have to go back. And now I'm eating my own words. Maybe I wasn't okay. Oh, we're back in action. Okay. Topic 3, the osteopathic model of medicine. You may not want to believe this or think about it, but all of us who came into the world through the birth canal, that whole process was made much easier by the fact that our skull bones were not connected, they were floating, they were overlapping, and they allowed the skull to be compressed to allow the birth process. We work with osteopaths and craniosacral therapists all the time. Anybody who's got a patient who has had a concussion probably had severe head trauma from a sports injury, from an auto accident, from falling down. And so we work with people who can manually tell us if the skull bones are all moving. Excuse me. We all had to learn the name of each bone. I won't do it here, but if you take the skull cap off, you'll also remember there were many holes called foramen, and you had to learn the names of every blood vessel and nerve that went in and out of it. You had to learn where it went and what it did. And if you're lucky enough to pass the exam, you forgot it. I was dragged back into this kicking and screaming, knowing that I have to be constantly aware of it. If you look at the mandible, it hooks up right by the ear. Now, this may be hard for you to see, but this is, and I hope it works, these are actual schematics of what an exploded skull looks like. And in a normal respiration of our skulls, can people see my face? I don't know if you can or not, but we've been breathing for 10 or 15 minutes without any effort at all. And unless you had a rib cage injury or a pulled muscle, you'd be totally unaware of your chest expanding and contracting nominally, but moving to squeeze air in and out. At the top of your body, your skull also has to do that. I don't think this is going to work, but I'm going to flip through it. No, it's not doing it. Every bone in that skull moves. Down in the bottom, in brown, is the maxilla. And when you can see this, you'll see the front teeth move in and out. Don't ask me what I think about fixed retainers on the maxilla. Inside, the brain is suspended in 4 sections, held apart by dura. If you could imagine the skull bones moving in and out, then you'll have to imagine that the brain, the soft tissue, gets pushed in and out as well. And that's what is the pump that helps pump cerebral spinal fluid up and down your spine. Dr. Mark Pick did this many years ago. So, in my world, life begins only when the pain ends and the fatigue ends. I no longer have a general practice, but Engineers build bridges. So do we. Is there any difference? There's expansion joints in bridges. There's all kinds of mechanical allowances for different temperatures. We put things in teeth that are quite rigid. How much coffee do we need? How many of you have seen patients walk into your office with a cup of coffee? How many people see them in cars? How many people walk around all day long? Why is this? We as a nation are exhausted. Start looking at the eyes of your patients. I have the privilege of not having to look in the mouth. From the doorway, I can tell how a patient is feeling by how they look. Now we're going to get into the meat of the subject. Appliance selection. I get asked all the time, what's your favorite appliance, David? What's the best one? And they're arriving on the market almost monthly. Some of them in the States are named after the inventor. I'm not going to mention any names, but there's no such thing as a Rawson sleep appliance. Not all appliances are the same. They have different functions. Depending who you're buying it from or working with, they'll give you different stories. But tonight you're going to learn with almost any appliance that's a decent one, you can achieve excellent results with not so much the appliance, but how you prescribe it. Those of you who have done any dental sleep medicine will remember the first appliance called the Narval, launched about 10 years ago. It was interesting story. ResMed is one of the biggest companies in the world of CPAP machines, and at a very high corporate level, they could see throughout the world they were losing business to the dental profession because we were starting to make appliances, and that scared them because when you sell a CPAP machine, like when you sell a car, you also sell ongoing maintenance costs. You have to get it tuned up. You have to buy parts. So if you lose money on the car, if you have a loyal customer, they'll be in your shop for years. So Narval bought the rights to the software to launch the first 3D printed nylon product called the Narval, and I was very excited about it, and I used it for many years. Not long after that, Pantera, out of Quebec City, basically jigged the software and launched a competitor to the Narval. They looked very similar, and for a while, excuse me, they were both available to we Canadian dentists, and I've used both of them, and you'll see in the study I'm going to present, they perform almost equally. Lots of pictures. Almost every month there's a new one out. This is called the SomnoDent, by now SomnoMed. A colleague in the States in California, Brian Karopian, had done a tongue restraining concept. His thought was, if I can hold the tongue down, I will avoid that picture I showed you earlier of the tongue and the soft palate and the tonsils collapsing. Made great sense. I tried it. Most people felt like they're being choked, but it worked. A nasal dilator, the Oasis appliance. A lot of these are very committed, hardworking dentists and medical researchers who are trying their best to make an appliance that can help. I want you to notice in almost all the pictures, the inner incisal or the interocclusal distance is 2 to 4 millimeters. Hold that thought in your mind because I'm gonna blow your mind in a few minutes. Excuse me, this is a local appliance. When I say local, my local lab, Shaw Labs in London. We started fiddling with our own concepts of Phonetic Bite and readily available materials. We didn't want to get into the patent process and pay a lab $500 or $600. So this is basically a thermoplastic night guard fitting on both jaws, connected by a Herbst appliance, a very basic orthodontic appliance. I do a lot of ortho, so I was very comfortable with using a Herbst arm. It's a fiddly one because you got to turn the key. Again, my cursor doesn't show, but you'll see a big pile, almost like a pylon in the middle, just behind the Herbst arm. And that is my attempt to create the vertical that you're going to learn about before the night's out. So we called this, locally, we called it the Shaw Snore Guard because we couldn't prove that it treated sleep apnea. So we called it a Shaw Snore Guard. We still have a number of these in use. They can stand up quite well. They're just a little fiddly to work with. This is a view straight on. It's hard to tell, but you can hopefully imagine that there's more vertical in the bicuspids than you saw in the other pictures. Both arches are covered with a thermoplastic base, and we've added some hooks for elastics for some people whose mouths fall open. This is a very interesting case. It's one of a kind. A patient who's referred many years ago, absolutely intolerant to CPAP with a full upper denture. And I really didn't know at the time how to incorporate the denture. And of course, he took it out at night because he was told to. So can imagine the distance between the nose and the chin collapsing by a good 10 millimeters, and probably not having the medical people understand, even though he might have had a sleep study and a CPAP prescribed to him, take out your denture and you've collapsed your airway even more. So I basically took an upper arch, boil and bite, and adapted a whole bunch of plastic and opened his bite by 10 or 15 millimeters, and he got off CPAP and he felt great. It was a very pretty appliance, but it worked. For some folks who would have a TMJ problem, we'd make a suck down base called a morning positioner. Some labs will make this for you automatically. Essentially, it's just a pile of pliable elastomeric material underneath a suck down base that patients would put in the morning when they got their appliance out, and would chew on that while they had their shower, got ready for work, which none of us does anymore. This was an appliance I made for a patient. I forget the specifics. I think he was a truck driver. I think he was threatened with losing his license. He was referred to me to my local ENT, and I basically very quickly opened his bite that much. You can see the blue hyphen on the side, and he did very well. So if nothing else, do not fear vertical. I'm here to support you. I'm not a big guy into academics and science, but it's well known that almost anything you put in your mouth can affect your airway and can actually affect the apnea that you may not know your patients have. So just become aware of the adage, don't turn a snoring patient into a silent apneic. In other words, you should always know what the apnea is. You'll get a pat in the back from the family when you get rid of the sounds, but you need to know the medical risk is not knowing that he or she is not breathing. This is too hard for you to see, but AHI can be increased by almost all kinds of appliances. Okay, so now you're ready to do what David does. What do I do? How do I figure out if I can help this patient? Well, range of motion is really quite simple. Anybody can do it. You stand in front of your patient, preferably standing up, not in a dental chair, or sitting on a chair in a normal position, and just ask them to open and close their mouths. Just watch their jaw. Does it track straight up and down, or does it go off to the side and back? Do their eyes wince when they go to do it? Even if you just do this for every recall patient, just make a mental list of the people whose jaws didn't seem to work as fast as they should. This is called a range of motion scale. You don't need this. You can use anything, but you'll see on the lower left a little semicircular cutout. This fits over the lower incisor, and as the patient opens up, you simply rotate it up, and the upper incisor rests against it, and you read off the number when they can't go any further. 40 millimeters and a sign of a reduced range of motion for whatever reason. So straight up and down, they should be able to open 40 millimeters, which is about 2 inches. Going laterally from side to side, they should be able to do 5 to 10 millimeters. Again, effortlessly, without stopping and without any audible sounds, either that you can hear. And if you're palpating at the same time with your 2 index fingers, you shouldn't feel a pop or a click. Patients who know, and here's a picture of it. So this happens to be a willing staff member many years ago whose jaw I knew worked well. And we hooked it over lower central, and we just said wide, 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 wide. And you'll see the upper central stopped at 45. So the range of motion would be recorded at 45. Anything over 40 with a complete lack of other symptoms is considered to be a fairly acceptable range of motion, and probably a patient that you could put very large appliance in to open up their airway. Very simple thing. How many fingers can you put between your teeth? Generally 3 is the same as 40 or 45. So 1, 2, 3. I had a patient call me up one day after treating him his jaw problem. He was very excited to say he could put 4 fingers in. It was a big guy, and I thought, really? That's amazing. I thought I was such a great guy until he found out this is what he was doing. You don't put your fingers in sideways. Again, remembering pain, TMD, airway, all connected. You're not TMJ guys, but having just thought about what we talked about, tomorrow, look at every patient after you've done your dentistry or you're doing the recall, just look at their occlusion and decide, I wonder if this person is what David would call a TMJ patient. I wonder if that means he or she can't open easily and quickly and to the furthest extent. I wonder if their occlusion is interfering. And so I'm going to present 7 or so patients that are all patients of mine. And if I did a full TMD course, at the end of it, I would ask you to write down yes or no. And all you need to do is look at them, and tomorrow look at your patient. There's a constricted maxilla. There's a 100% overbite, upper teeth slant inwards. And the answer to the question is half of those patients I treated for TMD and half I didn't have to. So it's not always what you see. Another missed deadline, a sleepy guy. Truck drivers live in absolute fear of being tagged with sleep apnea. The border has been closed to all of us except truckers. In the States, there's a very high awareness of it, and some truckers are pulled in to rest stops that are fitted with sleep clinics, and they can be tested on the spot and they can have their license pulled. I've had a number of arguments with truckers who would rather pay me off and say, just sign it and say I don't have it. And of course I can't do it because I'm also a citizen and I'm on the same road. Notice the eyes. Life begins when the pain and fatigue ends. Bite registrations. I'm going to step out on a limb and upset a good part of my profession, because those of you who know about George Gage and those of you who watch videos and are told how to make a sleep appliance, essentially you'll hear things like 2/3 to 70% of the protrusive is as far as you should go, or a good place to start. 2D means two-dimensional. In other words, move the jaw forward and back. It's obviously got to go forward. Why is it old news? Well, I didn't get into it much, but when you think of posture and balance, it's you need to remember that the head should be level and over the long axis of the tooth of the body. If your dental arches aren't aligned, in other words, if you have your neck offside, your head's offside because of a neck injury, so goes your mandible. So if you already start off with an uneven set of occlusal planes and you didn't know it, and all you did was go forward as you were told or thought was appropriate, you may not be getting the maximum effect. It's possible that the airway can also be distorted before you start. And so if you don't know that, then you may not be as successful as I want you to be. So I'm saying MAD is old news. MAD means mandibular advancement device. We're going to introduce 2 new concepts. MVD, mandibular vertical, is the better way, capital V meaning vertical. MVD versus MAD. The bulk of what I'm going to show you tonight is mandibular movement in the vertical plane. Think back to the condyle I showed you, think back to the glenoid fossa, and I'm going to present 3 cases that will demonstrate this works. And I first heard the term from Dr. Brendan Stack that vertical heals. I couldn't believe it, but I've proven it many, many times. So do not be afraid of opening bites. Less of what we're going to show you is moving forward. The bulk is moving downwards. You don't need the x-ray machine I have. You don't need to have the clinical skills that I have. You just need to follow these rules and you will not get in trouble. And I will help every one of you be as proficient at this as possible, because for every patient you help, they'll send 2 more of their family members, their coworkers, their friends. You don't need to worry about advertising. It will do itself. MAD, MV, small a. I did this on purpose. Capital V means the bulk of the movement is vertical. A little bit of it is advanced. So we're going to replace 2D with 3D. We're going to replace MAD with MVAD. Today's paradigm is 3 dimensions. We are 3-dimensional people. We look at bite wings, which are 2-dimensional. So what does MVAD accomplish? Why are we talking about this? Well, and if my videos work, I will actually be talking about this in a clinical situation. So rather than relying on an impassive and arbitrary mandibular measuring device such as the George gauge or other man-made systems, why not let the patient's nervous system guide us? Why not let the patient's brain say, here's where I need to go, doctor, because I know better than you. I've been with this patient all his or her life. The solution is the phonetic bite technique. I do this every day, all day long, for 20 years, for almost everything I do, and it works. So why not apply it to airway? Again, the title is A Bite Registration That Really Works.
Hello, I'm Dr. David Rawson, Clinic Director of the TMJ and Sleep Therapy Center of London, Ontario. My staff and I have created a short video for you today to demonstrate the application of the phonetic bite technique as used in dental sleep medicine appliances. Before we go chairside, a couple of words about the difference between our approach, which is three-dimensional, more holistic, and more in tune with the patient neurology, and the conventional two-dimensional approach that we take by looking at two sets of teeth and deciding what is a better position. We are going to take the onus out of the doctor's mind and out of the hands of the clinicians and actually ask the patient's brain neurologically, where's a good starting place for our bite registration. So we're going to extract the mandible from the cranium metaphorically and ask our patient to help us situate in 3 dimensions where the mandible would be best suited to open up the airway and reduce the amount of sleep apnea and snoring. We're now going to go chairside and demonstrate these principles in practice. We're going to go chairside and check our patient's occlusion before we actually take our phonetic bite. So our patient is going to demonstrate her normal occlusion, biting on her back teeth, and just step up a bit. And you'll see that she has an overbite of about 50% and an overjet of, say, 3 millimeters. What we're going to do is demonstrate, using phonetic bite technique, how her neurology will place her mandible in the most optimum place to maximize her airway. We do that by counting numbers using an S sound called the sibilant phonetic bite technique. Essentially a repetition of the S sound. So we're going to ask our patient to start by counting 66 and up into the 70s with me together, and we'll focus on how her mandible moves forward to create a small space to make that S sound. So when you're ready, we'll start with 66 and we'll count together. 66, 67, 68, 69, 70, 71, 72. You'll notice that every time she makes an S sound, can you do it again? 66, 67, 68. You'll notice that her upper and lower incisors almost touch. Her mandible has moved quite a distance to create that space.
This is actually a dental assistant who worked for us. It was unrehearsed. I knew nothing about her other than she was willing to be videoed. You couldn't see her face. And this was done just like I do every day. No rehearsing, just explain what I wanted to do. And her 50% overbite turned into end-to-end just by repeating S sounds. And I'll do it again from a different angle so you can see it coming on from the front of the chair. But essentially what she demonstrated is her mandible moved downwards and forwards and stopped just 0.5 millimeter from touching to make the S sound. You could make a sentence with S's. You could say, slippery spaghetti slid down the slope on Sunday, but who the hell can remember that? Everybody can count. 60s and 70s. En français, aujourd'hui. 60, 60. So now we're going to ask the patient to repeat a different number, being 75, and this will give us the maximum vertical opening that we want to record to start our sleep appliance therapy. So rather than count from 66 to 76, we're going to ask our patient to repeat the number 75 and drag out the 5 note like this. 75, 75, 75, 75. Thank you. Okay, now clinically what we observed was the maximum distance, can you open and close, that the patient demonstrated by holding the note 75. And what my assistant and I had decided was to use a series of round tubes or sticks that she will occlude on while we take the bite registration. So now we're going to place a round plastic tip, which is actually a disposable saliva ejector, and she's going to rest, you'll notice, in an end-to-end position
And I'm simply going to inject fast setting silicone bite registration between her upper and lower teeth to record that space. And when we have an excessive amount of vertical like this, you'll note that we have to be careful to inject slowly to record the occlusal surface of the upper and lower teeth. When I get to the center, I will move to the other side. Now we note that our patient seems to have slid forward a few millimeters, and we'll make a record of that clinically and adjust it in the lab. I'm just going to reach over to the other side and inject the other side the whole time the patient's being held on a round tube as opposed to a flat surface as in a George gauge application, because we want to correct any mandibular asymmetries. And I will hold that. My assistant takes the gun away and we just tell our patient to relax for another 30 seconds until we confirm it's quite firm. We, of course, in our office, record the jaw position in this bite registration, which we won't demonstrate today. So we'll now simply remove the tube. The patient doesn't move. We simply remove the tube. She doesn't want to give it up. She's a hungry girl. Thank you. Turn a little bit so we can show the people there's a fair size opening. You'll see in a few minutes how that translates to her clinically and on the articulator. Now we're simply going to ask the patient to work with the assistant to wiggle and slowly pull this out. And it was able to come out in one piece. Thank you. And this is a perfect record of her occlusion, upper and lower, and this becomes our phonetic bite for our dental appliance.
This is straight on view.
So let's do the phonetic bite. We'll start with 66 and we'll count up into the 70s. 66, 67, 68, 69, 70. Very good, thank you. Now we're going to do 75 and repeat it. 75, 75, 75, 75. Excellent, thank you. Now we're all set. So we're going to have you bite on this orange stick that's about the size of that space. And Fran's going to hold it. We're going to inject some vast setting silicone putty, and it'll only take about 2 minutes, okay? There we go. So if you can just close on that for us lightly. I'm just going to pull that back. Okay, good. Just like that. Thank you. And we are just going to reach inside, and if you try not to move at all, we're going to fill in that space. And if you want to move over, Michael, to get a closer look if you want. I don't know if you can see too much. I'm going to reach to the other side in a minute. There we go, and I'm just filling in the space slowly, and it'll start to harden pretty quickly. And in a minute, I'm going to reach across the front and do the same thing. And, sorry, okay? Mm-hmm. There we go. Super. She's not sliding forward, is she? Mm-hmm. Good. Excellent. I'm going to come across the front. And a little bit, oh, I guess that's good. That's great, thanks. Keep going, Mike. So we're not gonna go for a picture, but I'll just take the tube out and I can do a close in of what it looks like. Is that good?
You want to tell them or no?
Did you think you were going to? Probably not. It's probably a bit much, eh? Think so? Huh?
Sure.
Well, then we have to do a diagnostic one to show the difference. Would you let us take an x-ray? Mm-hmm. Okay. So don't move. I'm going to twist the stick. Oh, she's a hungry girl. You okay? Mm-hmm. Don't move your teeth. I'm just going to, there we go. Now you're locked into that purple stuff. Mm-hmm. If you just zoom in for a second, Mike, I just want to show the distance here. Good. Great. Thank you very much.
When she said 75, 75 and held that note, there was quite a bit of space between her centrals, and that's what we had. That's when we had her bite on a round stick, The reason for the round stick as opposed to, let's just see if I can bring this up to play slideshow, is that we don't want to include any cants, so the patient can roll from side to side. Now I'm going to actually show you 3 real cases with x-rays and the vertical this creates, and then show you how and why it works. So this is the patient's full occlusion, teeth together. You'll see some disc space, not as much as we liked before. And this is the phonetic bite position. What that means is, you heard me say to my staff and the patient, can we take an x-ray? We would normally walk out of the dental chair, walk around to the machine I showed you, and this would be how far the condyle has moved downwards and forwards with the purple in there. We don't even take it out of the mouth till after we radiograph it, because we sometimes, depending on missing teeth and undercuts, it's hard to get out and even harder to put back in. So we inject it in putty state, it hardens, we record it. It's like setting a bone. There's 2 red lines on this, and this is my own personal rule of thumb. I never let the mandible, the condyle, go past the height of the eminence of the jaw socket. In this case, we haven't, and almost every case we don't. But just look at how far the condyles come down and forward to get us the phonetic bite. Now we took it out, we cut it in half, and I'm showing you the part that scares everybody, because look what David did to the vertical of this patient. Oh my God, he needs to be shot. There's no such thing as opening the bite that much, they say. Here's a straight on view, so just back up to what we did a minute ago. We took it out, we trimmed it, and she's biting back into the left side. So that's another view of how far we've opened her bite. Then we take it to the lab and we mount the models. This is a different color, so don't worry about the technical parts, but this is essentially how far apart these arches are held with the technique of phonetic bite and the purple. Then we cut it in half, so when you look straight on, you'll go, oh my God, this will never work. This patient will never be able to function. How are they gonna eat breakfast? What's gonna happen? Following are 3 real patients of mine, identified by their initials only and their sex and their age. This was August of 17. I'm going to show you 3 different occlusions, a deep bite, a normal bite, and an end-on bite, because I need you to understand this works for almost all full dentitions. So this is a patient who presented 3 years and a bit ago. This was her normal occlusion. You would call that a deep bite. You'd be worried about impingement. If you look at the upper teeth, I talk about the garage in the car. The upper jaw, the maxilla, is the garage of your house. It needs to be wider than the car, which is the mandible. When there's a cross bite, or when there is buccal quarter slanting inwards, when there's anterior teeth pushed down or back, how does the full-size jaw fit in there? Well, it doesn't. It slides around and locks in somewhere else. This patient presented 100% overweight with a sleep issue. Lateral view. This is the patient's condyle in full occlusion. It's not in a bad spot. It's actually almost what I showed you to be a normal one. This is the same patient with the purple taken out of her mouth and just the model's handheld so you can see the vertical. This is a side view. This is a picture of the same patient's condyle with the purple in. We've moved it downwards and forwards, but remembering those 2 red lines superimposed, I'm a long way from exceeding my anterior limit. Another side view. Now we've made the appliance and we've delivered it and it's gone in the mouth, and we make some adjustments for lots of other reasons, but if you remember the backup one, I'm not going to do it because I don't want to lose my place. This mandible is a bit more forward of where it was on the phonetic bite technique. You don't need this x-ray machine. You can do this. Patient number 2, 48-year-old male. Beautiful occlusion, no missing teeth, healthy gums, got sleep apnea. He hates a CPAP machine. He wants something else. Great teeth. I wish all my ortho cases finished as well. Here's his condyle in a full occlusion. I know you don't have the machinery to do it, but I do. This is the bite wing I look for every day. I need to know where the jaw is and where it's going. This is his phonetic bite. Again, 10 millimeters, 11 millimeters, lots of purple. Don't worry, it'll work. I cut it in half so you can see the vertical. Essentially, about 10 millimeters between the bicuspids in a normal situation with a normal flat plane occlusion, no missing teeth, about 10 millimeters works. Here's his jaw joint in the phonetic bite, downwards and forwards, but a long way from the eminence. It's a bit fuzzy, but you can imagine it's a bit further with the insert of the appliance. Excuse me. Here's his Pantera, generation number 2, not the Narval, but the Pantera. Who can critique? What's the problem with this appliance? Anybody's? Yell out. Does anyone have a concern about what they see there, other than it's wickedly open? The answer
Heavy
is
loading on the posterior.
Thank you, Laurie. I rushed this to get my presentation ready for the talk we did 2 months later, and this patient would not go home like this, but it's amazing how normally those 2 flat pads are almost flat on by the technique we use with an aculiner articulator and all the technology that we use every day. So I would have, and I did, adjusted a bit, excuse me, on the posterior, just failed to take another picture, but that would not be, that's not what we'd want to deliver. Again, you can see an open bite. So it should be flat all across, but look at the height there. Number 3 patient. I know it's getting late, but I really appreciate your patience. This is 64-year-old male, end on bite. You're going to say, now what's going to happen, Rawson? How are you going to move this guy forward? Well, we're not. We're going to open him vertically. Look at his maxilla. He's got cross bites. His maxilla is already collapsed. He may have had narrow maxilla, end on bite. Some nice gold crowns, but a collapsed maxilla. For those of you who do ortho, this is like, it jumps off the page at you. This is his condyle in that occlusion. This is what it looks like with all the purple. There's where his condyle went. It didn't go way forward. It went mostly down, mostly vertical. And with the appliance still well within the 2 red lines of my comfort zone. Okay, just accept that I do this full time. Now I need to prove it. Every one of these cases, and I presented 34 in this paper, and you'll get the PDF of it. Every one of these patients had a sleep study pre-op and post-op. What I'm saying here is the reduction in AHI, which is the apnea-hypopnea index, which you all hopefully know to mean how many times did you have apnea or hypopnea of at least 10 seconds in duration per hour, not per night. People think if they get a score of 23, that wasn't bad because they slept 8 hours. It's per hour. Now, these results are of the 3 appliances I showed you before, the Pantera and the Narval. Narval, by the way, is no longer available in North America. The company pulled out about 4 years ago when they realized it was a lot harder to sell dental appliances than off-the-shelf machines. And I have a number of my own homemade Shaw snore guards. All 3 of these had the very same clinical protocol. There's the Narval. Now, I'm going to read this to you because you probably can't see it, but I presented this, and this is the data sheet. Across the top, Narval, comma, this is the type of appliance. The average reduction was 73.7% of a sample size of 14. When you get the printout, you'll see that the patients are named only by their initials. The first column is their pre-treatment AHI, their post-treatment, the amount of reduction in percent, the type of appliance. These are all N's because it's a Narval sample. And the category, for those of you who are just dabbling in this, it goes from mild to moderate to severe. Severe is 30 and above. There's no upper limit. I'm going to show you a case that's going to blow your mind. But just thinking about the Narval, which was the first launched 3D printed nylon product in North America, 14 patients, average 73%. Not only is this amazing, but compliance is almost 100%. If you talk to anybody who wears a CPAP, they'll tell you they hate it, they rip it off in the middle of the night, or they only wear it when their wife makes them to. Sample number 2, that's the Pantera that's still available, manufactured in Quebec City. Same chart without the color bars. Sample size of 16, average reduction 78.5. Medicine thinks if you can reduce AHI by 50% with a CPAP, and if you can accept that 40% compliance, which means 4 hours for 5 nights or 5 nights or 4 hours, is good enough, I say, pooey, why can't we do it every night and get 75% on average? Again, these are all patients, most of whom were in the severe category. Severe, dentists shouldn't touch severe because they don't think it works. This topic is to show you it can, and don't be afraid of it. And here's our homemade Shaw Snore Guard, a smaller sample size. You may be able to read this. 2 dropped out for some reason. Pre-op severe. These are both severes. If you look in column 2, you'll see patient PC had a pre-treatment of 64. That's a very high score. That means that person stopped breathing 64 times an hour for at least 10 seconds. Most of the time it's 20 or 30. When you do the math, they were not breathing for 20 or 30 or 40 minutes per hour, every night for maybe a long time. And you wonder why they fall asleep at their desk, why they're crabby and irritable, and all the other problems like increased blood pressure, increased risk of heart attack and stroke, and all the other comorbidities. You'll see that I reduced BB by 82 and PC by 76. So the numbers are 79%. Okay, now that was by appliance type. Now I'm going to do it by a category of severity of AHI. So severe, which is 30 and above, we had a sample size of 26. The average reduction was 76.8%. I don't think you're going to see it, but I have a bragging point that I am really very proud of. The moderate category, 15 to 30, the place that dentists are supposed to dabble in if it's okay with the patient and they hate CPAP, you can do that because it's not a severe condition. Sample size of 6, reduction 74.8. And all types of OAT, that means oral appliance therapy, sample size of 34. The range was from 15 to 113. This is the lady I want to tell you about. She came to us as a CPAP intolerant patient. Her score was 113. Just think about what I said a minute ago. 113 times an hour, she stopped breathing for at least 10 seconds. There's only 60 seconds in a minute. There's only 60 minutes in an hour. That's 3,600 seconds. Most of these patients hold their breath for 20 or 30 seconds. This lady worked out to, I think, around 75% of the time she was not taking in air, not breathing oxygen, and marvelously was still alive. The average reduction was 76.5% with this technique alone, irrespective of the 3 appliances I chose. So, is it the appliance? They were all prescribed, fitted, and titrated in a similar fashion. All patients reported similar positive feedback in terms of comfort, compliance, and bed partner observations. Going back to what I said at the outset, snoring versus sleep apnea, do not accept what the bed partner tells you. It's a very good indication that you're on the right path, but don't stop if they say, we're done, he or she doesn't make any more noise. You need to have a sleep study somewhere to confirm that you don't have the underlying killing disease called sleep apnea. The Narval category was 73.7. The Pantera, 78.5. Shaw, 79. If I can do it, you can do it. And that's why I'm here tonight, to at least encourage you to start thinking about the amazing difference you can do for patients in your office. There are hundreds in every practice that don't know you can do it. You don't know that they aren't sleeping. You probably don't know they have CPAP and they are struggling. Everybody's on the internet. Everybody's YouTubing. In your own office, what I showed you, you can do. You need a couple of round tubes, disposable suction tips. You need a quick setting bite registration and just a few minutes to relax and do this. And the vertical will work. Now, before I take questions, why is it so high? Well, when Arvell came along and said, here's the appliance that you should use, I said, well, what if I want to add to this? And they said, we can't do that. It's a one-shot deal. So I said, we're not going to do this, because they were showing it, and all the samples show it as a very thin layer. I said, I need 8 to 10 millimeters, and they didn't know what to do. They came back and said, we figured how to do it. So when I make my prescription and I have maybe 11 or 12 millimeters, I can very quickly reduce it in my lab, but I can't add on to it. So start big. You very seldom have to reduce it if you follow these guidelines. Summary: Narvell and Pentair are two of the latest. They were two of the latest CAD/CAM designs for dental sleep appliances. Both are similar. Only one's on the market now, but they're very light. They're very comfortable. It's nylon. We've never used it in the mouth before. It doesn't stain easily. It's actually very a comfortable appliance. We show an average reduction of about 75%. Patient compliance and acceptance is comparable. 84% of the cases were in the severe category. 84% of these patients were told CPAP or nothing else, and the doctors still don't understand it. So what's the future of oral appliances? Well, with efficacy of over 75%, if your doctor could lower your blood pressure by 75% with a simple medication or technique, wouldn't you go for it? Now, this is a little bit off track, but soon we'll have an ability to measure compliance, because one of the drawbacks for oral appliances was you couldn't prove they wore it. I get that. Everything I do for my patients is done at home. It's an appliance. They wear it all day long, or they sleep with it. It's not a filling I can watch myself make. So we have to be able to track it. But that's coming. Oral appliance therapy could and should be the treatment of choice for obstructive sleep apnea. You may know the difference between obstructive and central. We want to work with obstructive only. So thank you for that. Thank you for your patience. I know I went quickly, but I wanted to give you an overview of how I approach a patient. But most importantly, you need to know you can do this. It's not difficult. I know the first case you send, the lab is going to say, oh my gosh, just mention my name, and they'll say, okay, I know what's going on, because I do work with labs whose clients say, can you make one like Rawson? And they go, okay, but you have to admit it's a very big vertical, but it works. Vertical heals. AP doesn't. So if you can still hear me and see me, I'm quite happy to answer any questions about anything. There's no such thing as a dumb question. Did that make some sense? And who wants to go first?